to introduce these concepts a little bit. So of course, one of the reasons, and by the way, do we think long-term follow-up is important? Well, I think yes. So we've heard a lot of people who are sort of turned loose from their transplanters saying, I fixed you, go off and live your life, and then the insurance companies and all the difficulties being able to access care and expertise. And so we have to think about the practicalities of fighting for those things. But and I guess I could say right off, if people are having trouble, we'll make enough noise to blow them out of, So you can always contact one of us. So, that's why I put my email up there, and you can contact the Primary Immune Deficiency Treatment Consortium. And I think the new SCID Compass group, even though they're sort of organized for those first few months to years of taking care of SCID, they'll listen and connect people as needed. And of course the IDF will, and Heather Smith and the SCID Angels will. So I sort of think whether you like it or not, you've joined this family, this club, and I've talked to some kids who said, I don't want to be in that club. But there are lots of benefits. So these are things that I've talked about, the immune reconstitution, and of course this depends on what kind of gene you started with. Not only what gene, but what mutation in that gene, what happened before diagnosis. So was it newborn screening and everything was fairly smooth, or was there infection along the way? And those infections produce lifelong effects. And so those complicate transplant too. And so the way the immune system works after a transplant or gene therapy or enzyme therapy does depend on many different factors. So the mutation, who was the donor, and what was the protocol, was there chemotherapy, and all these things can influence what you get at the far end. And certainly what kind of chimerism, or that is what kind of mixture of the incoming donor cells versus the person's own cells that they started with, that matters and can change over time. And so just because it was tested 2 years after the transplant doesn't mean it's always going to stay that way. And chimerism, a lot of people who do transplants trained in oncology and learned how to do transplants for leukemia. And I think that's very important. And people with leukemia who go to transplant are not the plain old simple leukemia cases that respond to chemotherapy. These are people who didn't respond, whose leukemia came back, and so they're already really behind the 8 ball. And the whole orientation of that kind of transplant is, let's get rid of that leukemia, let's blast it as hard as we possibly can, and then rescue the person with a transplant. And obviously, they must give chemotherapy to hit the leukemia, and in the process that is chemotherapy preparative to the transplant. And that is often such intense chemotherapy that they expect complete chimerism. That is, the incoming cells take over completely. And then after that, when they measure that once or twice, they don't think it's necessary to keep measuring it because it was 100%. They're just happy the person is still alive 2 years later to measure it. And so that whole mindset is different for SCID, and we need to look at the chimerism in every particular lineage. So you can't just look at total blood chimerism, because that doesn't necessarily tell you, are there B cells from the donor, and only B cells from the donor might be likely to work in some of the SCID genotypes. So following these things over time is really important, and we've learned that even after decades, chimerism can change. So then the next thing on my list is chemotherapy late effects. And again, the oncology transplanters, they're just delighted that you're alive after a transplant. And so they sort of figure chemotherapy is part of the price of doing business. And it may or may not be something that they're watching out for in the more subtle realms. We think about chronic graft versus host disease, and that's a very tricky issue, because actually most of the time, it sort of depends on what kind of chemotherapy you got, and again, what the setting was. Many people who have some graft versus host disease soon after their transplant, or acute graft versus host disease, that can sort of slide into the chronic form. But there can be people who pop up with chronic graft versus host disease in a kind of a sneaky way that we didn't appreciate soon after the transplant. So that's another thing that I think we're still learning about. And then I listed infections twice, and that's partly because I started out life as a pediatric infectious disease person, and I got from there into host defenses, and from there into SCID. So that's not the usual path, but it means that I think about infections a lot, because I know how sneaky and difficult they can be. And I divided them into two because there are infections with consequences, and these infections might have occurred before the transplant or around the time of transplant, and then there are infections that might occur later. And then also I think autoimmunity is on the list, because a perfectly balanced immune system has checks and balances, and there are certain kinds of cells whose job is to keep other cells from getting too activated or off track. And sometimes those regulatory cells are actually deficient, and so paradoxically you get too much autoimmunity. Yes?
It's okay to ask the question in
Yeah.
presentation, but can you explain a little bit the difference between, in a patient post-transplant, the difference between chronic graft versus host and autoimmunity, if we assume that the patient's cells are not their own? Is autoimmunity post-transplant always considered graft versus host, and if not,
Okay, so that's a great question, because we think of graft versus host disease as these incoming cells attack the patient's tissues. So attack the patient's skin, attack the patient's liver. When we think of autoimmunity, we think of, and those cells, by the way, they're doing what they're supposed to do. They're doing their best, because cells have a job of recognizing foreign things and going after them and trying to get rid of them. So that is what would actually be a physiologic or proper reaction for mature cells from the donor against the host, if there's any mismatch of HLA. So the autoimmunity or immune dysregulation is after the stem cells have grown up in a person. They learn, in the process of growing up, they learn from their environment what self is. And then they also are supposed to make the kinds of regulatory adjustments to keep the grown-up, the brand new cells from recognizing and going after self tissues. And it's that failure of adjustment of the newly growing up cells that we think causes autoimmunity. So you're right, the cells are all from the donor, but in graft versus host disease, we think of them as sort of the leftover cells that came in with the stem cells, and in autoimmunity, it's the cells that grew up in the person. Does that make sense?
Yeah.
Okay. Okay, and I'm maybe kind of making this up on the fly, but at least it's my way to organize it in my own mind. So. Okay, and then the last thing on the list is genetics. So I just want to go, all right, now that you know everything I know to talk about, and of course you can add things to this list, I thought we might go back through these, and I want to hear from people who have a question or an issue with each one of these, and we can sort of talk about them. So does that sound like a good idea? Okay.
So the chimerism in all lineages. So the word lineages, is that the T, B, NK, and myeloid? Is that what the different lineages
are?
are?
So I'm saying hematopoietic lineages. Okay. So that means all the blood cells that are growing up from the stem cells of the transplant.
And can you have chimerism in one and not in the other?
Yes.
Okay.
So for instance, people, many patients who had T minus B plus SCID might have some of their own B cells, but those B cells don't work. So that's the case in X-linked SCID. And you might, from the transplant, get stem cells that grow up into some B cells, but there may be some of those leftover B cells around. And so that would be B cell chimerism. And it may be that every last one of your T cells is from the donor, but the B cells are a mixture. So that would be B cell chimerism with T cell, people sort of say complete chimerism, but it's not even a mixture. So chimera comes from this Greek word where there was a weird being that was a combination of different species, right? Like an animal and a head of a human and a body of a horse, that kind of thing. So that's where the medical term comes from. Okay, so just thinking about that, so numbers and function of the cells, the first thing on the list, so those numbers and function can change over time. So does somebody want to tell us about their own experience or volunteer something about numbers and function changing over time? Yeah.
Well, actually, it's excellent. Our son is 19 months post-transplant.
19 years.
I'm sorry, 19 years, sorry. big difference. He's X-linked matched sibling donor, and they're suspecting that his B cells might be starting to function, so we just actually are trialing off the Hizentra. My question was, could we do the chimerism instead of, would that tell you function? If he had donor B cells, wouldn't that be a better way to check for function than the trialing off and the vaccinations and going through all that and risking his health being off of the sub-Q?
So that's a great question, and I think this whole question about when to try to fly on your own without the immunoglobulin infusions. So actually, I would say what we would like to do is do both, the kinds of testing that you can do, and then also, if the testing is promising, undertake a trial off in the person. But so what I do is before I take somebody off immunoglobulin infusions, one of the things I do is look to see are antibodies present. And so, of course, IgG antibodies is not going to be very helpful because you're getting infusions of IgG. But IgA and IgM are antibodies that only the person can make. They're not present in the infusions. So if we see an IgA level that is rising up to normal ranges, or an IgM level going up to normal, that's an encouraging sign. And I'd say, lab tests can be encouraging, and I like to see a lot of encouragement from the lab test before I actually act on it. So that's the first thing that I look for. Then another thing is, would the antibodies that you're making, if you have some evidence that you're making some, and you look at the IgA and IgM, are they actually functional? So would they be protective? And again, we can't check that if we're giving you IgG all the time. So, but we're sneaky, right? So there are types of antibodies that are actually IgM that are specific. And one of these is called isohemagglutinin. Has anybody heard of those? So these are antibodies that people make to the blood group they don't have. So when you get a blood transfusion, if you're type O, you can't get A or B blood, and why not? So the answer is because you make natural antibodies against A and B if you're type O. Or if you're type B, you make anti-A, but type B is yourself, so you don't make that. So what we do is we check the blood type of the person, and then we look for these IgM antibodies that are naturally made against other blood types. And if we see a significant level of those isohemagglutinin, then that's also a very encouraging sign that your immune system knows what to do with exposure to a specific antigen. So that's another feature that would make me interested in seeing if somebody could get off infusions. And then chimerism, you're absolutely right. B-cell chimerism is something to look at, but that depends on the gene defect, because, for example, in IL-7 receptor SCID or CD3 chain receptors, the B cells are actually just fine. They're just waiting for T cell help. So it depends on the gene. And then in genes like X-linked SCID, where there are B cells made, you want to see, is there B cell chimerism? So with all that encouragement from lab tests on paper, then I would be willing to undertake a little experiment. And so this experiment is trialing off the infusions of IgG, whether it's sub-Q or IV. And it mystifies me why some people, some places say, oh, let's stretch out the infusions and see, like what happens. And I say, either you give it or you don't. And because I want to know, I want to know as soon as possible whether this is going to work. And of course, I'm very opinionated. So if you have a different, if your medical home has a different approach, feel free to challenge them and say, "Wow, this other person does it a different way." But so one thing is, I don't try this in November because I know virus season is coming. So I tell people, let's tough it out one more winter with the infusions, and then when spring comes, that's when we're going to trial off. And then, so we stop the infusions cold, absolutely. We do a couple of things. So, and we realize this is an experiment. And with all these promising tests that have been done beforehand, the experiment usually works well. I'm usually right. We can usually stay off, but not always. But what we do is we check the IgG level and see, is it falling because we're not boosting it up with those infusions anymore. So I would check it every, actually I'd probably check it in about a month, but I know that it takes 3 months for it to wash out of your system completely. So there's actually no point in giving vaccines before 3 months, which is why we start this in the summer, or in the spring. We want the summer to get you vaccinated, and then by the next winter you're protected. So, we're running out of time. Okay. So there are these studies where people would give vaccines or some kind of shots that are not in nature, that you wouldn't be exposed to. So it would be a way to give your immune system something that the IgG infusions never had. And that's, so it's hard to get a hold of. It's never been FDA approved. It's always, only through one institution. Another thing people are trying now is give typhoid vaccine, because they say, most of the donors from whom the IgG is made have never been vaccinated or immunized to typhoid, and so the levels might be low, and then we could see typhoid levels. That's something to try. I'm not against it. I'm not. If it works, it's fine. You have to measure the typhoid level, antibody level before, and then give the vaccine. And the vaccine's expensive, and insurance won't cover it. And then you have to measure the level after. And by that time, we could have tried being off and been done, right? So, but still, I think there's a lot of different ways to play this game, and so I would stop the infusions, let the washout period go by, check then how low has the IgG gotten, and get some antibody levels to the typical baby shots, like pneumococcus, tetanus, and so on. Then give those vaccines and check the responses. And that means by September or August or something, we know whether there's a good response. And by the way, there's nothing like looking at a patient. So if the SCID person starts getting sinus infections 2 months after stopping that IgG, that's telling you something. And then you can, that's part of the experiment. You see how you do clinically, and you go back on if you have to go back on. So you're sort of waving at me and saying that I'm blabbing too much, and I am. But I think it's possible that we could just integrate some of these questions into the experiences of adult patients. And so why don't we've sort of talked about numbers and function and chimerism a little bit. I don't know if there are any adults here who want to talk about numbers and function and chimerism. Or do you want to talk about something else on the list, or something not at all on the list? Yeah.
I've been wondering about my son. He has a chimerism. And I hear gene therapy, is becoming more relevant. And the transplant has always been kind of like a pseudo solution because he doesn't have B cells. And then I see the lobby full of vendors doing IgG therapies. And I'm wondering if he could get gene therapy with that chimerism, or would that be a contraindication for getting a gene therapy replacement?
Chimerism is not a contraindication. So, are you sort of thinking that the cells from the transplant could then fight against the patient's own corrected cells? And everybody wondered about that. And that was one of the sort of cautionary things that we all talked about before the gene therapy started. And now that there have been well over 120 patients who've been treated with gene therapy, and many of them have had previous transplants and chimerism, we've never seen a fight between the donor cells and the fixed patient cells. And I think it's because of this issue that the donor cells grew up in that person and learned what self is in that person. And so they're not likely to recognize the gene therapy cells as foreign. But that's a great point. Okay, why don't we, so I think a lot of people who are more experts than I am, because I'm not a transplanter, I don't give chemotherapy. So I want to list that because that's a big concern for individuals who did get chemotherapy. But let's go on a little bit. How about infections? So if we think about infections, by distant infections, I'm thinking, some patients, when they first presented with SCID, they had infections like meningitis, and that can cause deafness. And so some of those effects from infections will never go away, right? And so does anybody want to talk about effects that are lasting into adulthood from infections that happened early? Yeah.
So our daughter got about 30 to 40 days post-transplant, I think, got C. diff and noro in the hospital. So she had a lot of gut tissue and things that came out with that. Obviously, so she got better, but we've always had a question of whether we should explore it more and see what's going on there now, but also related to thriving, and we've all seen kind of kids are smaller, the adults are smaller, things like that. Is there any negative aspects of doing some of the things that we do, like probiotics and other things like that? So related to what she's had and, and such, are there any issues with things that we might do for a healthy child to boost up weight or things like that?
Well, so that's a great question. And it's several questions sort of rolled into one. So we recognize that some of these GI infections, including norovirus and C. diff, they just sort of rip the lining off your intestine, and you get this thing, we call it slick gut. It's just your intestines don't have the kind of cells that can hang on to nutrients, and they have to grow back over time. So they do grow back, and in fact, your intestines have stem cells, just like your bone marrow, and they live at the bottom of those little things called crypts that are, the up and down surface of the intestine. And stem cells grow up from there, and it takes them about 2 weeks to grow a whole new layer from the bottom. But actually, if the whole architecture has been disturbed a lot by infection, it takes longer. But I guess I would say they do grow back, and they grow back so that if we did a biopsy later, we could never tell that anything had happened. But it could leave, so some people actually have perforation, and then they need an operation, and their gut gets shorter, so they can have short gut syndrome. Some people have malabsorption, or some babies just don't suck a lot, and they sort of forget how to eat and swallow, and they need nutrition from a gastric tube or some other means. So, and fortunately, there are ways to provide nutrition that are elemental, that don't require a lot of digestive function, but they can be absorbed easily and used to grow easily. But I think if there's ongoing trouble with growth or with chronic diarrhea, and these infections have been looked for and they're not there anymore, that's when we start thinking about autoimmunity or immune dysregulation. And I think your question about probiotics is really interesting because we know that the relationship between a person's immune system and all the bacteria in their intestines, that's a very carefully balanced relationship. And antibiotics disturb it, and of course infections disturb it and other things. But we don't know enough about it to know what to put back. And so probiotics are just sort of fairly harmless, or bacteria that people have that you can buy, and they're not FDA approved, so you don't know exactly what you're getting from one bottle to the next. I think some of them are reliable and good, and some patients have found them useful. Another thing that is being done is actually stool transplants, and that's a little more difficult because there's a whole lot of different organisms in there, and you can't enumerate what they all are. And actually now there are studies showing that individuals with immune compromise who have received some of these treatments have actually developed infections with clinical infections with the organisms that were given. So I think it's something that we're going to have to learn a lot more about before I'm going to be comfortable with it. Okay, so other things about infections to think about? I mean, certainly one thing is the infections are sort of like a canary in a coal mine, that if you're getting a lot of ear infections or a lot of sinus infections, or I have some patients who just sound like this all the time, and their sinuses are just socked in. That wouldn't happen in somebody with a really healthy immune system. So it makes me concerned that we have to go back to the basics and look at that immune system and see, is that really okay? And of course, sometimes that might be allergies, and I have several patients who swear they got allergies from their donor, one guy who got a transplant from his matched sister, and she had horrible eczema, and he never had eczema. He had leaky skin, and he was a teenager when he got the transplant. Never had it before, and then after, he had it just as bad as his sister, and he kept saying, "You gave me this," and she would say, "Yeah, but I gave you a lot of good stuff." So I think sometimes it's allergies, but recurrent infections shouldn't be happening. And so somebody who starts getting ear infections who didn't have them before, or somebody who gets thrush who didn't have it before, that's the candida infection in the mouth. And that just shouldn't happen unless there's a reason for it. And sometimes the reason is you got a lot of antibiotics and your normal flora got messed up. But it's also maybe your immune system isn't performing as well as it should. And what are some of the other red flags of infections? Well, how about shingles? If somebody who got a chickenpox vaccine, or even who got natural chickenpox, any normal person has a low chance of getting shingles later in life. That's why adults get the shingles vaccine. But the chance of that is maybe 1%. And if that happens in somebody who's had a transplant for SCID, I don't like coincidences. And so I would say that is something that needs to be looked into. So I don't know if there are people here who've had a child or adults who've had shingles and then realized actually things are going south and they need to do something about their immune reconstitution. Anybody want to comment?
I also want to be cognizant of time. I know we have a panel of adult patients as well as parents who are also going to present after Dr. Puck.
Well, okay, so I want to hear from all those people.
Yes.
I mean, do we have any last questions about my list, or should we just go on?
We also have lunch after this as well. So as we are I'm happy to do whatever the group would like to do. I just want to be cognizant of all the time.
Is brain still considered privileged from any systemic kind of virus?
So say that again.
Is the brain privileged? I mean, they used to think that the blood-brain barrier would keep it out of the brain.
So it depends on infections. I mean, some infections are so awful that they actually go to the brain and target it. Like some of the herpes viruses go to the brain and cause terrible trouble. Or some bacteria go to the lining of the brain and cause meningitis. They get there through the blood system, and they get through that blood-brain barrier. Mostly, we actually think of the blood-brain barrier as a barrier to penetration of antibiotics or other things that we might want to treat brain infections with. So I guess it goes both ways. Yeah.
And just another point from personal experience, immune dysregulation, if you end up with hemophagocytic lymphohistiocytosis, HLH, that can cross the blood-brain barrier and cause damage to the entire central nervous system.
Absolutely, absolutely. And some of that damage can be irreversible. And so then you have to think, in adulthood, you have to keep paying attention to these things that happened long ago. Yeah.
Young adults who will become full-fledged adults and independent, the doctors and people. One of the issues I've had is I've experienced a lot of comorbidity, and obviously we don't know the whole progression of SCID, and I wasn't fully cured with gene therapy. Sorry. Could you not hear any of that? Oh, you okay? Sorry. So I was just wondering. If most of the time as adults we're seeing doctors who are near us, not necessarily like the top SCID specialist, which oftentimes we see maybe once a year, but how do we get doctors to sort of work together? Because a lot of times when I develop these comorbidities, they've sort of been tossed off as like, well, it's most likely someone like you who has a lot of conditions who would then develop something like this. I'm not really given an opportunity to try to connect some of the dots between the comorbidities, why I'm developing it. If there's autoimmunity, people just sort of like accept it, and then you're left to manage as best as possible.
Yeah, so I think you should come on up and, I mean, this is the thing, the panel perspective that, so what she's asking about is if you're experiencing symptoms and maybe you see a specialist once in a while, but how can you work with your doctor to get them to listen to you and to try to help you think about what you're experiencing in the context of what you've been through? Really, that's what you're asking, right?
Yes, and while I can't always go to the NIH, or we can't always go to our research facilities, and some of them might be really funding, and it's sort of a difficult situation, just to try to get doctors to sort of work together to try and help me find the answers really, and then collect that data so it can be part of our natural history for SCID, for this condition.
Right. Yeah, because if, I mean, this is a two-sided thing. So you're experiencing difficulties. You want to see if they connect to your SCID. And on the other side, we haven't seen very many adult patients, and so we don't even know whether that is a SCID-related thing or not, and we should be keeping track of it. So I would say the good news is we got email now. We've got iPhones. You know what? When I have a patient and they say, now I have this rash or I have this swelling in my knee or something, I say, snap a picture and email it to me. It's sort of cheap telemedicine, but you know, it just, a picture is sometimes worth 1,000 words. And I would say, email your specialist. Go bother your specialist during the year, and don't wait for that whole year to go by. And let's use our video chat and all these things that we've got to make those shared symptoms sort of, so we don't have to stick to one appointment a year. Because always when you go to the doctor, you're feeling fine, right? And then it's when you weren't at the doctor that those things come up. Right, and I think, that's, you didn't have a microphone, but that's important enough to repeat, that we can have a set of numbers that looks fine and still have a person who doesn't feel good or who isn't growing well, or, you know, there's things that we're not happy with. And I am the first to say we can do, you know, thousands of dollars worth of immune tests, but they are far from perfect. And those tests do not fully describe what's going on. So if I have tests in one balance pan and the patient's symptoms in the other, you have to weigh them, but you shouldn't give all the weight to the tests. You have to listen to the patient.
Thank you, Dr. Puck. So now that we've had an opportunity to hear from all of the top docs in their fields, we also want to
go learn.
Yeah, we're going to hear from patients and family perspective, because that's also a vital source of information, and those who have tread the path before us can offer much wisdom and insight. So we begin with a bit of a panel who can share some nuggets of knowledge and advice based on their own personal journeys. We have Wendy Bates, Jeffrey Nachem, Jerry Shorten, Heather Smith, Amy Walsh, and Sai Yun Wu. And each of them can give a brief introduction of who they are and share a little bit of their story. And then we can also open it up for questions. I will say lunch is from 12 to 1:30. So we are happy to extend this a little bit into lunch. If you have to pick your children up, they should be arriving a little after noon. So I'm certainly happy to have this panel run a little longer, but just be cognizant of the time and your children. Jerry, you want to go first?
Yes, ma'am. My name is Jerry Shorten, and I was born with X-linked SCIDs. I was diagnosed at 2 weeks old. I had two older brothers who had SCIDs too as well. That's how they was able to test me and find that I had SCID at a young age. And what else I was supposed to say? You said what? Oh yeah, that's right. My sister was my donor. It was a bone marrow transplant when I was 2 weeks old, and she was 2.5 years old. And I'm 32 years old. Right now, I am in real estate and trying to take care of myself. I do. I have a girlfriend I've been with.
Mom, but I know a lot of
Yeah, she does. I have a girlfriend I've been with for 3 years. Thinking about going there and proposing, and. Yeah.
I'm going to have Amy go next because I know she needs to leave shortly for the board.
Okay. Can you tell your health situation your health line?
Oh, yes, ma'am. So I am taking interferon. It's the medicine is called Pegasus, but they take the interferon out of the Pegasus. The Pegasus is actually for people who have hepatitis, but I use the interferon for my immune system, and I take the shot once a month. I did it whenever I was younger, but I don't do it anymore. Yeah.
Hi, I'm Amy Walsh. Can you all hear me? Right. Okay. Okay. I'm Amy Walsh. I live in the Chicagoland area, and I am mom to an 18-year-old Rag 1 leaky skid named Aiden, who just graduated high school. He is on his way to college out of state next year. I think he purposely picked somewhere to go far away. Aiden is doing well. He is still on treatment. He does sub-Q, and he was transplanted in 2006. He had a sibling donor. Aiden is my oldest, so his first transplant was cord blood, but he did require a boost of bone marrow. And we still follow up regularly and have a few I would say minor issues, and are just sort of watching and waiting and see how things go.
Okay. Hi, I'm Jeff Nachem. I have a daughter who's now 5 years old who was born with ADA SCID, and she had gene therapy. This was slightly before Virginia had newborn screening. So she was not picked up that way. She had, a couple of minor infections and failure to thrive and that kind of thing going on. And so, but she had gene therapy, and then she was kind of the outlier in the trial that she was in that, everything for her was going great. And then, per the comment you heard me make before, in the midst of that, she had some fevers and rashes that they hadn't seen before in a gene therapy patient, and they, after the fact, have kind of realized that was immune dysregulation, or they've said it might be akin to something called iris that they see in other types of patients who are recovering from bone marrow transplants, which incidentally they've also mentioned is something that may be more prevalent in the general SCID transplant population, but is often confused with GVHD. So one of your children may have even had this kind of immune dysregulation, but no one ever knew it because they just assumed it was GVHD. But with her, because it was gene therapy, they're like, well, it can't be GVHD. So, that's how they realized it was this other thing. So at the time, they were afraid to knock that out with steroids, so they just kind of let it be for a little while, and then it morphed into HLH, which is rapidly deadly and within 2 months usually, and if you don't get it under control within the first week or two, you can end up with organ damage and brain damage and all of this stuff. But because we were monitoring her so closely, they were able to put a stop to it, and they didn't follow the typical HLH protocol, which would have wiped out her her gene therapy or transplant. Instead, they just cooled it down with a long, heavy course of steroids. But in any case, so those are just some pieces of knowledge that may fit into this whole pearls of wisdom thing. But on more to the point of the kind of things they asked us to talk about here, I just wrote down a couple of things. Like I've guess in the discussion group seen a lot of parents who are kind of passive about, waiting for the doctors to tell them if this or that is working out okay, or they don't really understand what is in some of the lab reports. And so I think everybody should make more of an attempt to ask more questions at every visit, and figure out what the values and the different reports mean, because you really do have to kind of be your own advocate. Like the doctors, often they're tracking a lot of patients, even some of the best doctors, and I've talked to all of the nationwide experts, many of whom we saw sitting up here yesterday, and they can't keep track of everyone, so sometimes you need to call things to their attention. And even at hospitals, you have to be prepared to speak up, because nurses are going to do things that they're not supposed to, even at the best institutions. And then something in general is, I know we're trying to do this, but to come up with and this is part of the SCID compass thing, but the standard practices, we need to, kind of help families get a hold of, not have to figure this all out for themselves. I was kind of shocked when we were thrown into this that there, at how diverse the practices are and the different types of transplants and all the options, and it's kind of left to the parents to say, well, you decide,
We need
So-
to demand from the physician that they make best standard practices for kids.
Yeah.
So, yeah.
Anyway, I've been talking a long time, so somebody else. Here you go.
Hi, can you hear me? I won't be too loud. Hi, I'm Sai, and my husband's in the back there. That's Johnny, or he also goes by Richard. And we're from California, near San Francisco, and I'm mom to, I have 7-year-old triplets. I have 2 girls and a boy, and Jason has excellent SCID. He's called our newborn screening. Dr. Puck, we love her. She brought newborn screening to California the year before he was born, and so he's coming back from the field trip right now with his sisters. I think the thing I wanted to share was just staying connected, and I'm just so happy to see everyone here. I got to meet some people for the first time in person, and it's just been great. But I think that would be, I think when we started, it was just, it's crazy. You just are thrown this diagnosis that you've never heard of, and I don't even remember how someone told us about the listserv, so we got into there, and I know a lot of people are on Facebook for the SCID Angels and the SCID page. So hopefully, if you're not on there, please get on there while you're here, because and I know I've seen some of your posts, and he's just so knowledgeable. So I post like pictures, I'm like, what is this bump? And people there's like 10 responses. So just to vent, or even just to get advice. But I think that has been a really good tribe, finding your tribe of support, because it's a journey, because this doesn't go away, unfortunately. And so I think having that support and having a safe place, and meeting people who, even though you don't meet in person, but like really genuinely care about what you're going through and your kids. So that would be my 2 cents. Oh, and this was something new. Heather contacted me and some of the other moms in the Bay Area, but we are we have just like a support kind of group once a month at UCSF, and so I'll go, and it's for inpatient, outpatient, anyone who wants to come, and it's been great. I've met some inpatient moms and grandmothers, and they just can come and vent, just take an hour away once a month and just meet together. I know it's hard because everyone's so busy, but it's a great way to meet in person, and so hopefully that can be something that expand, because I think that's something great. Just I wish there was something like that when I was inpatient, because we were just stuck in our room all the time, never venturing out. So that's something to consider as you go home to wherever you are.
Good morning. I'm Wendy Bates McLamb. Whoops. Can you hear me now? Yeah. Hello. My son is Lucas McLamb. He is 13, and I think we're one of the few, for some reason, there's not a lot of these 11, 12, 13-year-olds. I don't know what happened, but anyway. He was born with IL-7. He wasn't diagnosed until he was 8.5 months old. He had his first hospitalization. He was born December 29th, 2005. He was hospitalized for the first time about mid-May of 2006. And from May until about a week and a half before Christmas of that year, we were only home for maybe 20 days total. I used to have that number in my head, but over time, we try to pack it away. Yes. We were mostly in the local children's hospital, and he had constant infections and mostly they were lung infections, and they thought he was aspirating, and we did the Nathan fundoplication with the Mickey button placement, and he still had aspirations, they thought, but actually Lucas was dying from PCP pneumonia. And I will never forget the day I looked at, I'm trying to find nice words, because we love our doctors, we really do, but sometimes you meet one and you say, I looked at him and I said, do something. I said, take his boogers and see what it is. And he said, we don't do that here. So that night, I sat in, if you've been in PICUs, they're basically the same at every hospital. You sit, you have a wooden rocking chair you sit beside. And I sat and I prayed over my son. And I told the good Lord, I said, please don't let him suffer. And that's the one thing that got me through all this, is my faith. Because the next couple of days, he was like, So when his diagnosis came, or his suspected diagnosis came, it was an AI fellow at that local children's hospital that said, I suspect your son has SCID. I said, what? She said, do you have babies that have died? And I said, what are you talking about? It's very overwhelming. It was very, I don't know. There's a lot to take. I was alone. I was a single mom, and he was my third baby, and all I knew that he was dying, and all I could hear was her words, if he makes it through the transplant. And we were released from Winston-Salem, North Carolina, on a Wednesday in August. I drove to Durham, to Duke that night. I found a cheap hotel, and we slept there, and we were in Dr. Buckley's clinic the next morning, where she used words like H-flu and used the big word for PCP pneumonia and inpatient. And suddenly, there was carts and things wrapping us up, and here we go. But I knew it's okay, because again, my faith was there. And I also learned it's okay to focus on the now. It's okay to not exactly know what's going to happen next week, but to know that right now we're going to be put in this room with this. And it's okay for that. And as a mama, that's hard, because we want to plan. So, Luke was transplanted on September 26th of 2006. We weren't allowed to leave because he also had RSV. We couldn't go to the Ronald McDonald House because he also he was failure to thrive. When we got to Duke, remember he was 8 months, going on 9 months old. He was only about 11, 12 pounds because they only taught us how to do bolus feedings. So we hooked up to that pump, and Dr. Buckley plumped him up. And we stayed there until right before Christmas. And then we were fortunate. It's a difficult journey. And I have to thank the good Lord that children being born today don't have to go through my son's journey and don't have to go through some of these others' journey because of people like Barb and like Heather and all you others that have been such advocates, and you've worked so hard, and like Dr. Puck, to get this newborn screening. And if you have to become a member of this family that you don't want to be a member of, it's just the best time to be a member of it. It really is. It really is. Because, you know, who is it that says you are my people?
Yeah.
Yeah. These are our people. Yeah.
And everyone, it is 12:05. The kids have not arrived yet, so I'm welcome to let everyone continue talking, and I'll chime in again when the bus has arrived. You're welcome.
Well, and I'm Heather Smith, and I feel like probably people know who I am, so I'm gonna go really quick. I've had 2 children born with X-linked SCID. My first son, Brandon, passed away at the age of 7 months, and my second son, Taylor, is turning 24 at the end of this month, and he just graduated college, and he is about to undergo gene therapy. But I want to let you guys ask questions of everybody else. We kind of have different stages, as you can tell, of life up here, so hopefully there's somebody here that can answer any questions you might have, whether you're somebody who's been picked up through newborn screening or whether you're somebody who's got a teenager or whatnot. So if anybody has any questions for us, we'd love for you to ask us questions. Anybody have anything or anything?
So for the folks with older kids, my question is, I've heard anecdotally that moving into the preteen and teenage years that you can expect, or that it's possible that there'll be things you need to look out for, or there could be changes outside of typical peer-aged puberty type things that you could expect related to post-transplant or related to SCID or whatever, but I have never heard any specifics. And so my question for you all who have gone through teenage into adult years is, was there anything moving into that sort of pre-puberty teenage stage that as SCID parents you need to be aware of?
I can share my experiences, although,
you know, it's my experience, so I can't say that this is true, and the physicians in the room can maybe say whether it's something that they see in all patients. So I mentioned Aiden is RAG, which comes with its own unique sort of problems and issues. But when Aiden got to the age of about puberty, and that also happened to be about approaching 10 years post-transplant for him, because he was transplanted at the age of 6, right after he turned 6. So, and he had a late puberty. So that's one thing I will say. He hit puberty about the same time as his younger brother, who's 2.5 years younger than him, and their growth patterns were about the same as well. So although they were both born at the same weight and size, and maybe in the early years had that rate, Aiden kind of stagnated for a little bit and then was about the same size as his brother, and they happened to hit puberty about the same time. So Aiden had a little bit of a later puberty, but we did notice at that time he started to decline somewhat in his cell function and in his cell numbers too. So about that time is when it was mentioned that not right now, but in the future, we may need to get more cells from his brother. And then it sort of shifted to his brother as a carrier. Some of the problems Aiden was having, could that be related to his donor being a carrier? And if we were going to repeat a transplant, would we want to look for another donor? So those are some things we're still thinking about and we haven't answered, and we're, seeking other opinions and following all the right people, I think. But that's our experience. So.
Rachel, that's a great question, and something that I thought of while she was talking. For us, what I'm thinking is IVIG related. Taylor always had rate issues with IVIG. We had to go super, super slow. He reacted to IVIG as a young child, and so we ended up on GammaGuard SD. Otherwise, he would vomit and get a headache. And Alyssa's telling me, is it
the children are here? Yes.
Okay.
The bus is pulling in right now.
Okay. So I'll go as fast as I can. So anyways, at that stage, it was taking like 12 hours to go for his infusion, because we'd have to go so slow, or otherwise he would get sick during the infusion. After puberty, that changed, and he now can go at a much faster rate, and so that so someone who has had reactions maybe as a younger child something in that stage, I think, with the development of his body and whatnot, has made it so that he now tolerates it much better, and it's like a 4-hour infusion now. So, so you guys don't have kids, I guess. Okay, great. Great. Anything else? Any other?
So this is maybe for Dr. Puck, but for all of you too. I'm very curious about long-term follow-up. We just had Ryan's 4-year post-transplant appointment, and I was kind of taken aback when the immunologist was like, so in our eyes, he has a normal immune system, so from an immunology standpoint, we don't need to see him for 2 years and then maybe 5 years, but he is going to be followed by endocrine very closely because he had chemo and he's short in stature, he has some thyroid issues, so, but that concerned me, and he was like, you know, the protocol is constantly changing, so this is what it is right now, could change in a year or two, so do I demand him to be seen once a year? Like, how do I go about this?
So, Bridget, that's a great question too, and it does change, and it depends on who it is that you're seeing. And you know, I think we all can agree that it takes a team of specialists to make up the care for our children, and I think it's always going to take a team to take care of our children. But you need that one person that's calling the shots. Our case is a great example. So Taylor does get seen annually every year, but then I've always pushed to make sure that he gets seen annually every year. And if you went to every other year, I think that would be okay, but if you went longer than that, we would have missed his decline in his function. And so it was me tracking that and graphing it and seeing it. And it was over a 3-4 year period. So if we had gone to 5, we would have missed it. And now we're ahead of the game, so he's doing so well without getting infections. So going into his gene therapy, you know, we've already been told he's the healthiest patient that's going to be getting gene therapy. So that sounds funny, I know, right? So you might say to yourself, well, why are you doing it? Because the numbers are showing that something is continuing to happen, and he has chosen not to wait until that illness gets him, because we're hoping that the outcome is going to be better than what they've ever seen before. So that's the hope. So if you're not doing that monitoring, there's those kinds of things that you can miss, because he's not getting infections. So it's not, you know, just going to the doctor because you're getting these recurring sinus infections or something like that. So my advice to you is to continue with at least every other, if you're not going to do at least every other. And if your immunologist doesn't feel that it's necessary, then I think you need a new immunologist. So that's my personal opinion, that as a parent.
So I have to head to a meeting and have to leave, but I did have a question for some of our panelists, even though I was up there. So I'm going to ask it, and then I'm going to ask all of you to fill me in on what the answer is, because I have to go. But so I think all of us in this room who are here are good advocates for our children, because we have to be, and because we're here. I mean, that proves that we're trying to advocate for our children. And in part of that, advocating for them is preparing them to someday be adults, to be heading off to college like my son, graduating from college like Taylor, or, Ashanti and Jerry, who are now on their own. So I look to all of you to ask, despite thinking that, I hope that I've done a great job in setting him up for success, at what point did you feel confident enough to understand your own labs, to ask the right questions, and to be knowledgeable on your condition? And do you feel that you're still learning, or are you at that point?
Definitely. I'm learning every day. I'm 32 years old, and I've been born with this, so this has been a part of my life. I don't know anything else different. And my mom, which she just left, she was really the one that stayed on top of me the most. And whenever I was younger, she would start telling me to take the steering wheel of my appointment and start asking questions, start going there by yourself. You know, she'll send me in there and she'll be in the lobby waiting for me. And I think that really helped me to grow up. And this condition does make you grow up faster, because there's certain things that I couldn't do that my other friends was doing, and it has to be a choice. I went through a weird phase in my life where when I met Heather for the first time in New York, we was on a Phil Donahue show, and I came back, and
These guys are too young. They don't know who Phil Donahue
Yeah.
is.
I actually
Back in the day, he was like the Oprah Winfrey.
right.
So it was really a big deal. Taylor was just a baby. It was like 1995 or 6. Yeah.
Yeah, Taylor was a baby, and I actually have a picture of Taylor that I'm holding Taylor when he was a baby.
Yeah.
I actually did not like Phil Donahue, by the way, but that's a different story. I wrote him a letter because I was really upset with him. So, and I met Heather in New York, and I forgot where I was going with all this.
It was a tough time of your life.
It was a tough time. So when I came back to school, I got made fun of because I was on TV, and I was like, it was mixed emotions. I'm growing up, I'm trying to be somebody, and you have this condition, and you can't do certain things, and people are treating you a certain way because they say that, oh, you have the cooties or whatever the case is, and I'm just like, no, I'm actually cleaner than you. You're the cooties. Right, you don't get me sick. So I did go through a mixed emotion where I did not accept it, and I just wanted to be normal, and I didn't, take my medicine, and I didn't want to go to the doctor, and I didn't want to follow the protocols that my doctor was trying to give me. So it just took me just growing up and going through some challenges in my life to figure out how important and how big this really is, and if I don't stay on top of it, I mean, I could, lose my life. That's exactly what I was at. I went to a point where I just didn't care, and mental health is really strong. I'm part of a company that we do work on personal development. I think personal development is really big, and a lot of people don't teach that. They don't teach that in school, personal development. I mean, even people who are not sick, that the people that's out there in the world, they need it too, as much as we do. And so I learned that at a younger age, it just helped me grow up faster.
That's a great point. When Taylor was younger, we did some TV things like Jerry said, and so he was always just knowing his story, and that we were very open about it. But as he became a teenager, he went to a new school. He no longer wanted to be identified that way at all, and so he did not want me to share his story anymore, especially at school. But I felt that it was important that the school know about his condition, at least the teachers. So if something like chickenpox came down or something like that, they needed to be aware. But we no longer identified him as the person that you needed to be careful that they could catch it. And that was a hard phase for him to go through, but he did get over it, or I shouldn't say he got over it. He did go through it, and I learned from him that I needed to respect the way that he was feeling, because kids are cruel, and they're very, very cruel, and so you have to be very careful there about what you as the parent may be putting on their shoulders. But he did get to a phase himself where he was 18 years old and went to the immunologist and said he didn't think he needed his IVIG anymore because he wasn't sick. The IVIG was keeping him healthy, but he wasn't sick, and he wanted to go off of it. And I'm sitting here pretending like he's not in the room, but I can see him out of the corner of my eye. And she said to him, if you choose to go off of IVIG, I'm not going to be your doctor anymore because I have tests right here that show me that you need it. And that was all he had to hear, was that he needed it, and she had the documentation to be able to show it. So you may get to that point with some of your kids where they feel like, we're doing so well on IVIG, why do we need it? He didn't remember being sick. He never was sick. He was transplanted in utero. He's only hospitalization he's ever had in 24 years was when he had Lyme's disease, suspected Lyme's disease, because you don't know for sure whether he did. And that was just a short hospitalization. Other than that, he's never been hospitalized. So he doesn't know what being sick is, you know. And so I applaud his immunologist for being able to say to him, but here's the proof of why you can't. And that was because we had checked all the lab work, like she said. We knew we have trialed him off before, off of the IVIG, and he did not succeed with the vaccines. So the data was there.
Can I say something else?
Yes.
So to go back to your question, yeah, I'm guessing you have a son that has SCIDs, right? And he might, you're afraid that he's gonna not want to do his medicine or anything like that. Just stay consistent, but don't pressure him where it's like, I have a hard time explaining this because my mom at one point, she pressured me where I didn't want to do it, and then she just kept staying consistent with me, and then she made it to a way where I didn't feel like it was pressure to do it. I felt like I was making the decision to do it, and she broke it down where it was that I understand that this is really important. You know, you only have to do this once. You know, you do this, and just kind of just stay consistent with them and just work with them, because we're hard-headed when we're kids. We think we know it all, and we want to just do our own thing. And my mom was my biggest advocate for sure.
All right. Thank you, everyone.